Carol Petersen, welcome back to the podcast. Happy New Year. It's lovely to see your face again. And I'm not just saying that.
Thank you, Chemaine. It's my pleasure. Happy New Year to you too.
Yeah, and it will be. It will be a Happy New Year. I can feel it in the air. I wanted you to come back on the podcast and fill in some gaps that we didn't get to. You're a wealth of knowledge, and honestly, I could probably do a 5 hour podcast with you, but your schedule doesn't allow that. So this time, I want to fill in the gaps around administration and dosing, and I have a couple of more questions that haven't so much been covered in your other conversations that I'm hoping that we can fill in here. But let's get into it because I have a list and I have
Okay.
a mistake. All right. So if the first thing is, and we can get into the whole estrogen topic again. And we did in our last conversation, we discussed hysterectomies and estrogen breakthrough, and we discussed a lot. But just to start with a basic question, which do you think a woman is better off starting with? Progesterone therapy or estrogen therapy?
100% progesterone.
And if their symptoms don't improve,
Um, Depends on what symptoms they are. If they're progesterone deficiency symptoms, you need to use enough progesterone so all is eradicated.
mhm,
If it's estrogen deficiency symptoms, then you start adding estrogen and testosterone and DHEA, thyroid support, whatever else
mm,
needs to be addressed.
mm. A primary symptom being a hot flash or night sweats, probably the out of all the
Progesterone.
symptoms in perimenopause, they're the biggest pain in the ass. I
Yeah.
mean,
And that's because conventional medicine is saying it's estrogen deficiency. No, it's
mm,
progesterone deficiency.
yeah.
Dr. Jerry Lynn Pryor just published a study showing success, very, very good success with 300 milligrams of progesterone.
Mm,
What I believe it's more likely to be the cause of hot flashes and vasomotor things is insulin glucose. When glucose drops, you get a surge of adrenaline. This is what I believe is underlying this whole situation. Now, progesterone helps stabilize that,
mm,
but you have to go even deeper than that and work on the insulin glucose swings.
yeah.
But
Yeah.
that clears up really quickly with progesterone.
Yeah. The reason this was my first question is someone had mentioned they just got a blood panel back from their naturopath, and the naturopath said they needed estrogen for their hot flashes.
Yeah. I think
So,
some of it, and I've spoken about this before, way back when, and I don't recall what year, when Premarin was approved, they were approved for only one thing. It's not approved for menopausal therapies, it's approved for vasomotor. But Premarin, last thing I found was had 60 different steroidal hormones in Premarin.
yeah.
And some of them estrogenic, some of them progesterone-like, some of them testosterone-like. Um, and so I think more than just the estrogen portion of Premarin was contributing to the vasomotor response. Now, having said that, it's kind of in our vernacular, in our thoughts. One of the other things that happens in perimenopause is also known as a time of great change with estrogen going up and down and up and down, sometimes very rapidly. And this too may introduce some vasomotor responses, but probably mediated through insulin and glucose. A height of estrogen will throw you into um, a low glycemic
Yeah.
state. So perhaps adding estrogen can be helpful to stabilize that, but I would still go to progesterone first, maximize with the progesterone what your own estrogen can do.
Mhm.
And again, I said insulin glucose, that's your destabilizing thing.
Yeah. And I think we both agree with what Dr. Platt says. There's a big adrenaline factor. I know for me, there is a big adrenaline factor there.
Yeah, and the biggest problem, I called him the other day.
Yeah. I
I
have to
said,
actually speak to him today.
I called him and I said, there's, I see high adrenaline everywhere.
Yeah.
And I said, you have any tips for me for bringing it down? And he said, do you have my food plan? So I didn't. He gave it to me.
Yeah.
And I think he's right, but he also doesn't have the answers for once it's out there, and if you're poor methylator and can't get rid of it,
Mhm.
what to do, because you're stuck with it, and you can be stuck with it for long periods of times if you don't detoxify well. So I've been on the hunt for multiple solutions to try to get that taken care of.
From my
Before,
conversations with him, I think some of it is out of his scope of practice. So I started in nutrition and orthomolecular nutrition, and I've been doing this forever, it feels like. So then some of the practices I had brought up to him, he hadn't heard of before, which is great because I was able to teach him. And adrenaline, like it's not surprising why everyone has so high adrenaline, whether or not you had it from childhood. The whole COVID pandemic, it just scared the life out of people, to put it bluntly. It did, and people
right.
didn't recover. And so now, like for me, I'm using at nighttime because sleep is my priority when I'm looking to optimize anything. I'm not compounding, I'm stacking GABA with magnesium, with tulsi, with glycine, with collagen, whatever I can do to get that stress response down. It's not like a one trick pony, it's loads of different things. And I don't think people understand that. You can't just take one adaptogen like ashwagandha and expect miracles to happen. That's not how it is anymore.
And certainly progesterone is probably the most direct and the most helpful of the whole thing you said, but I also will stack things. And I want to give you a pearl that I just learned, actually from Dr. Richard Johnson, who's over there in Calgary.
Oh,
And
cool.
he used to work with schizophrenics, like Abe Hoffer identified adrenaline getting metabolized abnormally to adrenochrome. And that's when people would hear voices and hear weird things telling them to do things, was that adrenochrome, which Dr. Hoffer identified and named. And his treatment was high doses of niacin and high doses of vitamin C.
Mm.
So Dr. Johnston has used this therapy. So I called him up and I said, um, with this high niacin, high vitamin C, work with my high adrenaline people who
Mm.
are struggling at perimenopause and andropause and everything, and even the younger ADDs, and it's everywhere. And he goes, no, just, but he said, this is my top trick for that. He said, exercise.
Well, yeah.
And then I spoke to the mom of a 20-year-old autistic girl, and she said, Hannah went to bed last night. She woke up during the night. She bounced on her mini trampoline for 5 hours and then went back to bed and slept till 1 o'clock.
Yeah, because she was exhausted after 5 hours.
She burned off that excess adrenaline. So she's having detoxification path, and we're trying to work with that. But like she instinctively knew what she had to do. Then another gentleman I was talking with, he said, you just took me back to my childhood. He said, my dad always made me run. And I used to think that my dad wanted me to be an athlete. That's why he was forcing me to run all the time.
Mm.
But he said, now I realize that he was just getting me to be calmed down, because otherwise I was bouncing off the walls. Way too much adrenaline and energy. So
Mm.
you can use that, and I think you should use exercise as a tool, and it definitely can help.
There's a dopamine factor as well there, though, because exercise stimulates dopamine and doesn't progesterone and dopamine. Well, progesterone has activity on the D2 receptors as well. So there's a lot happening there.
Okay, I can't deny or confirm. I just don't know.
Okay. But then also with the rebounding, for example, like rebounding helps with circulation and moving lymph and that
Right.
detoxification as well. So it's not just one level, we're working on many levels, just moving our body.
Exactly. Exactly.
Does
Or
that
like,
doctor still practice in Calgary?
no, he's retired.
What were his doses, do you know?
For niacin
And the vitamin C.
oh, huge doses. Look up Dr. Abe Hoffer.
I will.
He came from Victoria, and it was several hundred milligrams of niacin, and then of course thousands of units of vitamin C.
That's super helpful. One of my clients is struggling with a family member, and schizophrenia just came on in 2024, and it's been horrific for them.
Mhm.
And I've been sending a lot of research around progesterone and different therapies. Every little helps. So, moving on, I wanted to ask you this. Why is there still so much talk about estrogen, even from like some well-respected practitioners? Not to name names, but Sarah Gottfried would be an example of people would know her. And there's a lot of what we would call highly respected doctors and functional medicine practitioners. They're still pushing the estrogen topic as if it's the holy grail.
Well said, Chemaine. I wonder that myself, but this is the position of the North America Men- um, Menopause Society or Menopause Society. They've dropped the North America. Um, American College of Obstetrics and Gynecology, the Endocrine Society. That's their positions. So depending on what your doctor is doing, there many of them are required to observe these positions as standard of practice.
To keep
But
their
then,
license, is it maybe?
yeah, yeah, yeah,
Like there's external influences?
yeah.
Hmm.
Now that doesn't explain Sarah Gottfried, does it? She's off by herself,
Yeah. And
and
she's got
and
quite a name for herself too. But
right.
maybe it's so ingrained in her that she struggles to shift that kind of idea.
So then we also have to sort out like where in the lifespan are we talking about? In the perimenopausal years, generally there's way too much estrogen. And here's where I think estrogen is being used appropriately. Jerry Lynn Pryor again published that during a woman's lifespan, the estrogen is the highest in the perimenopausal years. But then you hit menopause and all that cools down, so to speak. And then you probably do need estrogen to support yourself if you want to have good quality of life. I've got nothing against estrogen. I just want to see it used appropriately and always in balance with progesterone. Now,
Mhm.
we've been doing this for decades. Again, policies and positions, the Menopause Society, Endocrine Society, who's responsible for those women who had a hysterectomy, they only need estrogen. Now, why would all these intelligent physicians go in lockstep with that philosophy, knowing darn well there's no hormone that acts on one organ, one organ only. And those women who've had a hysterectomy desperately need progesterone. They wouldn't have gotten to that place in the first place if they had enough progesterone. So there's this. It's almost like they write it in stone and say, this is if you I can't tell you how many people have talked to me and it's still going on. My doctor says I don't need any progesterone. I had a hysterectomy.
Mhm.
So this is from Ray Pete. He says those women who are getting estrogen only, and if they're low thyroid, and sometimes one is caused by the other, your prolactin levels are going to rise. And then secondary to prolactin levels going up, parathyroid hormone goes up and sucks calcium from your bones. So
Mhm.
that one hormone, after your doctor's devastated all these hormones, they give you one back and they say it's for your bones. You got to take it the rest of your life to protect your bones. And those doctors are actually giving women things that are slowly and steadily leaching out their bones.
It's almost like they actually don't know what they're doing. They're just
Yes.
following the book, and they're like, if they listen to how you just explained it, it's pretty obvious. But, that whole hysterectomy topic, I told you about this in our last conversation that they offered me one at like 31. Laughed at them. Are you crazy? But it's so upsetting. I spoke to a client the other day and she's in her mid 30s and her sentence just took me back. She said, "Oh yeah, I had a hysterectomy, but it was essential. There was no other option." And that just left me speechless how undereducated women are in
Yeah.
this. Like, you want to keep your body parts, they belong in your body, not in a jar somewhere.
Exactly. And yeah, that disturbs me very, very much. I just got an email from a woman. I kind of like to touch on this because she told me she just had breast cancer treatment, including removal of her breasts and chemo and radiation. And supposedly not the BRCA gene, but some other gene. And she's going to proceed to have her uterus and ovaries taken out. Now, her mom and her grandmother did have some endometrial cancer. So she's concerned she's in this victim kind of situation where you are your genetics, and it's absolutely untrue.
Mhm.
Current they're finally shifting a bit to give up this genetic thing, and really, I've seen numbers such as 90% of breast cancers are epigenetic, that
Mhm.
it's environment that brings the causes to you. So this poor woman wanted to know if she should have her hormones. I said, whatever for. I was just like, um, there's no, if you're going to proceed with surgery, there's no point to look at your hormones now. And then after her surgery, what's going to be her fate? Most likely they'll tell her you can't use hormones.
Mhm.
Because you're at high risk. And it's all of this is a lot of it's based on
Fear
uh,
mongering.
fear mongering and studies done with things that aren't the real hormones. Uh, the progestins are a big problem with cancer. They can be cancer inducing or promoting, and they wipe out your progesterone.
So is this woman still going to go ahead with everything?
Yeah, I just kind of gently told her to look at. I have some resources on my website of different books you can read on breast cancer because it does come up, and I'm always giving people books to read.
Mhm.
I said I should just put it on my website and save me some trouble. And
That's like it's heartbreaking. She's almost going to be left an empty shell after all this. Like it's just heartbreaking. And what's your quality of life? Are you even yourself anymore after you've removed your breasts and your uterus? Like I don't know. Like, obviously, I'm not in that position, but then I'd wonder, would I rather just live my last few years if that was the case, being myself, or living in fear as an empty shell? Obviously, that sounds insensitive, but it's shocking. The whole lot's shocking to me.
not totally shocking to me. And I certainly and it makes you pause just as you're talking about what would I do for myself? Would I be so wrapped up in fear I just go submit myself to the chemo machine, or would you actually seek something else out and do your best to find out where has your body gone wrong? I don't think it's gone wrong. My personal belief at this time is that, and I've heard this from several resources too, that cancer is part of your immune system protecting you.
Mm-hmm.
And now there are people saying cancer is a fungus. They find fungus and parasites inside the tumor. Actually, one person, I spend way too much time on Instagram, but but sometimes you learn a few things. This surprised me. Any kind of growth, like fibroids and ovarian cysts and fibroid cysts, we should be looking at parasites. Why don't we routinely do this as a first line and say, let's fix this at first. Let's clean this out. Maybe do some liver detox first, because if your liver is challenged with trying to detoxify and not doing so good a job, let's make sure that's all working. Let's make
Mm.
sure things are working, but before we jump to the conclusion that our body's betraying us, I don't think it is.
No, I don't. And there's obviously a lot to be considered, including mindset and all that. But I don't think if I was in that situation, I would go down the path of listening to conventional medicine, partially because I'm too strong-headed. But as well, I did have a run-in with cervical cancer back in 2019, and that's when they offered me a hysterectomy. And I was like, nope, nope, no. I said no to everything. And I was like, I'll do this myself. There's nothing wrong with my body. And at the
Mhm.
end of the day, I was like, if anything is going to make me sick, it's going to be stress. It's not going to be anything else. It's always the stress. So I want to just move on. While we're on the topic of estrogen, I have to ask this because people say this all the time. Why do you think some women do get relief from hot flashes and some of the symptoms with just estrogen?
Do they?
Yeah.
For one thing, I have certainly known women taking estrogen only after hysterectomy, and they're in their 80s and still have hot flashes.
Mm.
So there, there is that situation, which I think is unacknowledged. And then I would believe that if this offers some stability to you when you have wide swings of estrogen, probably helps. But I look for other estrogen symptoms, particularly vaginal tissue. If you really need estrogen, your vaginal tissue atrophies pretty quickly. So that's my prime signal that yes, that woman needs estrogen. Their whole body estrogen isn't holding it. And that has big implications all over the body that you do need it. So I don't know.
Yeah, no, I don't think it's accurate either. Anytime a woman has said this, and a woman said it to me recently in a consultation, she's like, I said, why are you taking the estrogen? She's like, well, it helps with my hot flashes. And I'm like, but you're also taking progesterone. So maybe it's not the estrogen, maybe it's the progesterone. And she's like, oh, but I only ask it because people still say this all the time.
Yep, I know. We're in a estrogen-centric culture. There's a book, The New Menopause, which I don't really recommend people read if unless you want to know what the different groups are telling doctors. This is Mary Claire Haver. She's
Yeah,
got
we
a
spoke about her the last time.
yeah, she's got a million followers. So I did read her book. I did publish a Substack with Liza on Becoming on the things that she misled people about, I believe. And she's got a whole telemed section put together. And I've already had some clients that were failures of her telemed. So yeah, I don't know what she says, how she said, and the failures even were on estradiol and progesterone, just that they were terribly not balanced, not enough progesterone again.
Mm.
So she barely mentions progesterone in the whole book. It's estrogen everywhere. And I don't know why. It's a
Well,
very,
like we
very
mentioned, maybe external influences there. I mean, she's doing pretty well for herself, so.
yeah.
One thing, and we're going to leave the estrogen here, but I just want to just jump back to this. I know you've said this till you're blue in the face, and I wouldn't ask it, but there's still some fear around this. And I did join the estrogen dominance support group because I've been in touch with Kitty Martone and noticed still in there some of the comments of women afraid to use progesterone because of the estrogen kickback or breakthrough. So could you really just quick just tell us again what that is and what we do about it?
Okay, well, where I started out, actually compounding with Women's International Pharmacy, we started with progesterone in capsules, and we were basing our work on Katerina Dalton's work on PMS. Her starting doses in suppositories were 400 milligrams, 600 milligrams suppositories, used multiple times per day. in some cases. And so this progesterone in oil was being compounded as a possible alternative. Our starting dose was 400 milligrams and up from there. And I've seen women use thousands of milligrams before they got relief.
Hmm.
Um, After a while, I began to wonder why that was. Now I know better. Um, you're trying to balance stuff. You're trying to balance histamine, adrenaline, estrogen, the whole kit and caboodle. So it's taking a lot of progesterone to get there, to get the comfort. But then I think we should investigate the other. But how women got to these doses, we would call them breakthrough.
Hmm.
Let's say they were taking, say, progesterone 100 milligrams 4 times a day in the luteal phase, doing pretty well.
Yeah.
And then one day, they're not doing so well. There's anxiety is back. And so the doctors that were working with these women would give them extra doses. They would give them lozenges or a cream or a vaginal insert or a rectal solution, anything to get the progesterone back up.
Hmm.
And then curiously enough, John Lee, who did do us some good favors about learning about progesterone, he also heard us because he publicly spoke about your body makes 20 milligrams of progesterone and you don't need any more than that. Huh. And so we started at Women's having a lot of women call in because of Dr. Lee's influence, and they were using like little bits of progesterone. They're using Progest 16 milligrams. Remember the milligrams I was talking about for successful treatment. So if you have this estrogen breakthrough that we saw, you say you got to use more progesterone. We knew from this experience that this worked.
Hmm.
And so, what are all these Progest women? Not everybody. Some women did fine on Progest, but there were a lot that didn't.
Hmm.
And we, because of our background, would say, oh, well, you need more progesterone, a lot more progesterone than you're using. And sometimes they would change and get something prescribed for them. Um, John Lee at a conference in New Orleans covered this situation, and he said, well, there have been complaints about the protest causing more problems. And the more problems are more breast tenderness, more headache, or new onset, even higher anxiety. Just women can be rushed to the hospital because their heart's beating out of their chest. It's happened with those low doses. And so women some of them have come to hate progesterone and know positively they can't handle it because of those low doses. And Kitty Martone's group calls it the estrogen kickback.
Hmm.
I think that's accurate. But I think there's adrenaline involved in that too. This heart
Yeah, I
palpitations,
was
I
just
think
gonna
that's
say. Hmm.
more adrenaline than estrogen. So I think that that term needs to be revised. But I have seen in the literature, they call it progesterone inversion, where the low doses produce adverse effects and high doses produce the effect that you want and need. So yeah, it's a big problem.
I
Another
wonder, just as you're speaking, I'm trying to think, how can I simplify this? I wonder if it is that your adrenaline and your estrogen are so high and they see a little bit of progesterone come in, they're like, oh no, we see what you're up to. As we say in Ireland, they say, get the fuck, and they just increase all these symptoms to overcome that bit of progesterone. It's like your body senses, oh, you're trying to get rid of us. Well, we'll show you that kind of thing. Um, yeah.
that's yeah, that's an okay metaphor. But progesterone is such a busy hormone. It does so many things, and you introduce it back, even in a little amount, it's going to put activity getting started all over in that small amount. Just does not begin to compensate for everything that hormone should be doing for you. And balancing estrogen goes right out the door. If you have no corticosteroids, progesterone will get diverted quickly to help you out there. It's not going to balance the estrogen. So in that sense, it's an estrogen kickback. Um,
And this
far.
would account, sorry to interrupt, but this would account for women who haven't had a period maybe in years and they start using progesterone and they'll have a bleed.
Okay. When I just talked to somebody, and that's one thing I try to have everybody know from the get-go. In the second part of the luteal phase, progesterone, when there's no ovulation, it becomes a secretory hormone. It allows you to shed the endometrium. So if you've gone for quite a while with not enough progesterone, as soon as you start using it in doses well enough, there's going to be bleeding.
Mhm.
And I ran into also a client, she went through 2 weeks of tests at her OBGYN and other people to rule out that there was cancer there. And it's predictable, 100% predictable. If there is tissue there that needs to be shed, progesterone will help you shed it. So
Mhm.
what do you do when you start bleeding? I suggest you just keep the progesterone up, and the bleeding period is going to be heavier, but it'll be shorter too.
Mhm.
If you say, "Oh, I'm afraid to use progesterone because it made me bleed," but no, that's a happy event. This is not a sad event.
Mm. It's like a
And
flushing.
yeah, you don't want that there.
Hmm.
So if you stop the progesterone at that point, what women tend to experience, they may still bleed through, but it'll be spotting for weeks on end while this is all happening, and all the more nervousness to go to their doctors. And their doctors should recognize this.
Hmm.
But they put them through they're obligated again by standards of practice to treat it like you have cancer.
Mm. Well, you mentioned the corticosteroids there, and that was actually one of my questions for you. I was speaking to a colleague the other day, and we were talking about the pregnenolone steal, progesterone steal, whatever you want to call it, and he mentioned he wasn't convinced that this was a real thing, because we were discussing high adrenaline and estrogen, and I said, well, there is an aspect of the pregnenolone steal there, which I do think is real because I do experience a lot of stress and I notice how it affects my hormones. But what do you think about the pregnenolone steal? Do you think it is a solid theory, like it is implicated in stealing our progesterone?
Okay, that's really a good question. And now there's some debate about this going on. One lab owner said progesterone doesn't turn into um, corticosteroids, but does he have evidence for pregnenolone? I don't know. Some people say that pregnenolone makes progesterone and it makes hydrocortisone or cortisol
Mhm.
separately,
Mhm.
and that there's no pathway for progesterone to make cortisol. Although if you look on flow charts with all the hormones, how one becomes the other, it's certainly on there that it does. And now to confound things more, I was reading an article about progesterone in men yesterday, and they said, well, the ovarian progesterone doesn't convert to cortisol, but the adrenal progesterone does. Just
That would make sense because we make cortisol in the adrenals.
I don't know when that makes sense. Yeah, it does.
But that's so funny. You saw me smiling there. Those were his, I don't know, were you speaking to the same guy? I was speaking, it was Paul Robinson. You probably don't know who
No,
he
I
is,
don't know.
but he literally said the exact same thing. He said there is no direct pathway. And he also said the graphs that we're all familiar with seeing, they're just pretty much generic medical graphs and they don't actually indicate what's really happening, which of course is super confusing for everyone now because that's what we thought was happening.
Well, maybe yes, maybe no, because if you get the more technical ones, they have all the enzymes involved in the reaction. And this particular comment said that the ovarian-based progesterone couldn't be converted to cortisol because these two enzymes were not available to the follicle or to the ovaries.
Mm,
But the adrenal could, so because they did have those very enzymes they needed. So I think it's really illustrative that there is so much after all these years, whether you say thousands or millions of years, we don't understand
mm,
about the complexity of our body. Yet one of the most important things in this whole story is we can't rely on the tests. We've got to rely on our results.
mm,
Now, having said that, if you get estrogen kickback and you have a negative result and you don't know any better, that's dangerous. Or what I think is dangerous, and I mentioned this decades ago,
mm.
if somebody is using low doses of progesterone, and back to John Lee, he said, go ahead and use it for 9 months, you're going to be fine. That had an accumulative effect, but I already knew from the PMSers this could be gone in an hour. So why
Yeah,
would you wait? Why would you wait 9 months?
yeah.
So
Or 10 minutes, depending on your burn rate and your metabolism and
it's so quick how it can flip. And then there's a lot of fear about going up to higher doses because some of the higher doses that I've seen before it becomes effective, again, hundreds of milligrams, thousands in a few instances. But what are
mm,
you working against? You're working against tremendous adrenaline that you're having trouble getting rid of. You're working against, it's a secondary detox. Methylation is for histamine. Progesterone is really good as an antihistamine to prevent histamine being released in the first place, but it's no good to deal with the histamine you've already released, and then all the estrogen that needs balancing.
mm.
So there's it's so sweet when you can just flip it, and I have to push clients in the beginning. I had one yesterday, and actually it was at her 3 month period of time. I was so happy. She was uh she um she was whiny.
You're like, have you taken your progesterone today?
Yeah, so now at the end of this time, she's all smiles. And her psychologist has said, what have you been doing? Yeah, I haven't seen you this calm in ages. And she also found a way to help with insulin glucose, following the glucose goddess. And I think there might be some pearls there. And she said, I have to thank you for encouraging me to go up to 1,100 milligrams of progesterone right from the get-go, because that's where she found relief. And that's what
That's a
gave,
lot. Yeah.
it gave her the hope and the understanding that she could do something to improve that terrible situation she was in.
Is she using cream or how is she administering it?
She's using cream, I believe.
Because you're in Canada too, for everyone who doesn't know, and immediately our brains are screaming, "Whoa, that's a lot of money to use that much." So it is what it is.
Right.
So you mentioned testing, and this was what we didn't get to last time. Um, what's your opinion on testing? What are your favorite forms of testing? And I don't know if you'll add it in, but I will add it in case you don't. I'm sure you'll agree. Sometimes testing in perimenopause is not definitive because women's hormones go up and down and up and down. And one day everything could be tanked, and literally the following day everything could be peaked. So it's not definitive, in my opinion.
Right. So then you look at some other markers, like I mentioned, prolactin in the
Hmm.
serum. That would be useful if I think that you have estrogen excesses.
Hmm.
And it's no good to look at one estrogen, estradiol, no matter which dosage form, I mean, which kind of testing you look at, whether it's urine, saliva, serum. If you look at one estrogen body at any one time has 20, 30 plus numerous xenoestrogens from our environment,
Hmm.
looking at an estradiol level gets you nothing, zero. So prolactin gives you a little more information that you have an estrogen burden or not. Sex hormone binding globulin is kind of useful because if it's gone high, it does go high with estrogen stimulation and cortisol stimulation. So even though you have like your total testosterone DHEA, it looks okay, you functionally don't have that working for you as well as you could. So it tells me you're off balance with estrogen. So
Hmm.
you can get some clues. You can do serum homocysteine and see how well you're methylating. It's a good indicator. I also look at creatinine. Now in the serum, if that's running low, that's a methyl sink. Those same methylation groups that you need to detox will make your body will prioritize making creatine
Hmm.
first. It's a methyl sink. So if you take creatine as a supplement, make sure your body has enough, then you have more available for detoxification. So there's a lot of hints you can get from testing. 24-hour urine is kind of good to look at your corticosteroid reserve with all the metabolites. I kind of like that.
Hmm.
There's this theory, not written in stone, that 4-hydroxyestrone, 16-alpha hydroxyestrone are too stimulant and DNA disruptive and whatnot.
Hmm.
4-hydroxy means you're not making enough methyl hydroxy from that, and you need to methylate it to bring that down. So another sign of low methylation. 16-alpha hydroxyestrone, that just tells me that your iodine and thyroid are low. That's what's needed to convert that to estriol. That's how I use those particular parameters as hints for that. But then maybe I've asked for a serum panel, for a whole panel for thyroid. I can see that there too. So there's different things you can see. And the other thing I think is truly a travesty is if you don't know your total cholesterol, you don't know your insulin glucose measurements. These are probably some of the most important things for your hormone status.
Hmm.
And a lot of tests just don't go there. Metabolic tests for serum do go there. But the other so-called tests offered for hormones
Hmm.
leave that out. And insulin glucose is a much more powerful hormone system than the adrenals and the sex hormones. So you got to have it. Or they leave out vitamin D.
Yeah.
If your vitamin D
Because
is
in
low,
Alberta, you can't get vitamin D tested. You have to go yourself and find the test. I can't remember, but there's some regulation in Alberta about testing vitamin D.
so if your vitamin D is low, your hormones aren't going to work.
Mm.
So if you haven't measured and don't know that, you don't know that you have adequate vitamin D, you're like inside of a paper bag. You just don't know.
Mm.
And vitamin D is so subtle. It's not like progesterone where you can see dramatic relief from symptoms in hours.
Mhm.
You take a vitamin D capsule, what do you feel? Nothing. So, so we almost have to test to be able to have that just basic piece of information.
What are your like if you had to pick one, what would be your preferred way to test? So there's the serum, there's tissue in regards to hair and nails, or there's the Dutch test, there's a saliva test. If a woman, because this is the question that they ask, what should I test? Like what would be the one test I would do?
I have my wish list with tests. This is what I ask my clients to do if they want to dig into what's going on with their body. And this is especially important in perimenopause. And it's a metabolic panel with all the hormone systems included, because you have to look at all these things in relationship to each other. Like what's going on with your hemoglobin and your red blood cells and white blood cells. Are you overexpressing white blood cells? So there's infection. Now we have a source of where all this stress is depleting all your cortisol. It's enormous amount of information. But I'd like to start out with that. And then do we need follow-up testing? Now, that's not so important to me
Mm.
because, because for the most part, you get some good results with making those changes. And unless at the end of making the changes that we do on the basis of that test, if there are still long-lasting, naggy kind of things that we haven't identified, then I might do it again
Mm.
to see what may have not shifted. and that I can't put a finger on. So that's my preferred. Dutch is way too limited in the scope of hormones. Like I said, if you don't know insulin glucose, everything that Dutch tells you, throw out the window because you don't have the most important.
Mm.
And um,
Unless someone was to pair their Dutch with a blood panel from their family doctor as well, that would give you a more rounded idea.
yes, but with the metabolic panel, one of the advantages is you have one system you're looking at serum, and all these things relative to each other are valid because you take it at the same time, the same serum. Now, when you're trying to bring another test in that's now in urine, which is not the serum, it's like the day after.
Mhm.
So you have to make adjustments for that. So nothing that Dutch says is got anything over what I see in a complex metabolic panel.
Where are you doing, or where do you send people to get their metabolic panel done? I think it's on your website, if I'm correct.
Yeah, it's on my website, and I actually had it done in Canada with nurse practitioners. So there were a few analytes they refused to test,
Mm,
and then there were a few I got billed for that weren't covered.
yeah.
But for the most part, I was satisfied with what I had because I gave them everything
Mm.
that I wanted to test. So that would be one route.
And was it pretty affordable with what you had to pay out of pocket for the extras?
Out of pocket for the extras was about $400 Canadian.
But it gave you a full picture, so
Right, right. The panel that I have posted on my website, $1,000 US.
yeah. Whoa.
Yeah. So,
That
so
makes everyone second guess. Well, maybe I'll just live with my symptoms. So,
that's
okay.
that's why I was so pleased.
Yeah. Moving on, because we're the clock is ticking here, but we're covering so much. We're yay us. What administration? Okay, all the different forms of administration we've mentioned before. Myself and yourself, we love the creams, but what are other options for administration? What are the best ways to use progesterone? Is there specific times? Don't think we really need to get into dosing because we already spoke about that.
Okay, so oral works. I know from years of compounding it works, except for those few who seem to make a lot of allopregnanolone from it
Mm-hmm.
and the drowsier. I'd avoid it if you had a disturbed microbiome leaning towards candida. I'd avoid oral.
Mm-hmm.
Having those oral capsules are kind of nice because you can insert them vaginally, you can open it up, squirt it in your mouth, you can crack it open, rub it in on your skin. All that's good. You can do that. Um, Creams are good, except when you're so low thyroid that the circulation to your skin is impaired, and so are your body oils, because part of the progesterone is in suspension in the cream. You've got to get it completely in solution in oils
Mm-hmm.
before it gets to your skin. And I've been thinking recently, this high adrenaline state gives you cold hands, cold feet. So you've also got impaired circulation to your skin. So
Mm-hmm.
the very time that you need it the most, you may have the hardest time getting it through your skin. Um, I saw on Kitty Martone's page, women were freezing their cream,
Mm-hmm.
and
Making suppositories.
yeah,
Mhm.
how clever is that? And recently, Joe Mercola says you can buy, at least in the US, you can buy progesterone powder.
I
Get
found
liver.
it on Amazon here in Canada, pure USP progesterone.
Great, great. So you can mix that with vitamin E. Actually, you can mix it with just anything if you wanted
Coconut oil, I was thinking, like a good coconut oil.
or if you had a cream and you want to bump up its strength, you can put it in there. So that's really
I'll just
great.
add it to my tea. I'm just going to drink it all.
Oh, it's not water soluble. So, what you should have it with a fat.
Mhm.
Having progesterone at meal times, this is from Michael Platt, helps moderate that insulin glucose swing. A lot of progesterone is just being prescribed at night. That leaves you anxious all day. I don't like that.
Mhm.
I like the doses staggered throughout the day. Got one client she feels best in having her progesterone every 3 hours. If she deviates, tries for 4 hours, she starts losing it.
Mm.
So divided doses, I think, are very, very helpful.
Do you think, apart, we've already spoke about like vaginal application, but without freezing and just applying the cream and massaging it around the labia and whatnot, there's a higher absorption rate there through that tissue than there would be to say apply it to your forearm or your chest. Am I correct?
Right, the transmucosal,
Hmm.
or like with Joe Mercola, the transmucosal tissue in your mouth with the progesterone and vitamin E.
Yeah.
There's absorptions and improve that. You can use it rectally too.
You know,
It's,
I don't know if you know, Onas, they have a progesterone tincture that
mhm,
you can take orally.
mhm.
So I actually ordered that. Be interested to try that. I was hoping that would be an option to bump my progesterone instead of just going around loads of cream all over me all the time.
It is. It is. So I don't have a particular favorite.
Hmm.
I gave you some situations where it might affect how you use it. Others maybe simply what you will actually do. Like if you only want to swallow capsules and not mess around with the cream, it may be fine for quite a lot of women. They don't have to do anything. The point is that you have to get enough progesterone in to behave like progesterone.
But if you do the capsule, it has to bypass the liver. And if there's liver issues,
No,
okay.
no. Actually, this has been published in several places, and they say this all the time. But some of the original literature actually it gets picked up by chylomicrons. It's treated like a fat by your body. It doesn't go to the liver first pass.
Where is that in the small intestine that gets picked up?
From the stomach,
Okay.
chylomicrons. This is how you absorb any kind of fat. So it goes into your ends up in your lymphatic system, which may be um contributing to weird levels with saliva testing stuff when you're actually on it.
Mm.
So first pass effect doesn't mean that you are avoiding breakdown of liver.
Mm.
In about 90 seconds, you're at the liver. What is the reason for avoiding the first pass is that you have an enhanced concentration of the hormone right in the place where you use it. So it's helpful to put it on the breasts if you have swollen breasts, because when that gets absorbed, those receptors right there will get it first. But it's going to the liver right away. What protects the liver, and it really does protect the liver, is avoiding all these synthetic analogs that deviate from your body's biochemistry. These
Mhm.
are a big problem for the liver.
Yeah. And that's what Dr. Platt teaches us is to apply it so it goes directly into the bloodstream and attaches then to the receptors. Okay, so I wanted to finish on one or two last questions, but controversial. Why not go out with a bang? I did hear you mention this before, and it caught my attention in another podcast. I think it needs to be brought up is the connection between the COVID vaccine and how that affects hormones and
Yep.
even how we utilize progesterone.
Huge. There have been studies published both that the long COVID or maybe post-vaccine too is wiping out all our corticosteroids, cortisone and derivatives. And I even saw a study done wiped out progesterone. The vaccines right from the get-go have been causing huge increase in the rate of miscarriages. And this is just like really soon after doing a vaccine or having COVID. So it's a big interaction, and progesterone should be helpful when you have that kind of situation. You really haven't snapped back after being sick. Look at your corticosteroids, look at progesterone, supplement it, and you'll see a big difference.
Last question, not so controversial, but I just wanted your opinion on this. I heard another practitioner mention it recently, and she mentioned that in the research, we see that low estradiol is a driver of cancer. Have you heard that? Low, so not high, low estradiol.
Um, I don't know. I don't know.
That kind of caught me off guard. Maybe you'll look into it and let me know. But when she said that, I was like, yeah, I've heard high, but low, that I don't know. I don't know. I can't comment
I
on.
think when it's high, you have to ask yourself, maybe it's not the estrogen itself, maybe it's coexistent with other things, your inability to detoxify in
Mm,
general. If estrogen's accumulating, you're accumulating all kinds of things. So it might not be fair to just blame estrogen, although it is a growth promoter. We know it from
mm.
how it builds up the endometrium every month.
Yeah.
So things are not as simple as it seems. I had one client who had breast cancer and she went to Mexico for treatment. She
Hmm.
had breast implants. I told her she should have them out. You would think that would be the first thing, but she didn't want to have them out.
Hmm.
And that's a big source of toxicity as far as I'm concerned. She used her hormones all the way through, flew through the whole treatment, which was not the chemo radiation, it was hyperthermia, Scully's toxins, a few other things, lots of coffee enemas, for instance, lots of detox. And now we're 2 years out. She's clear and never stopped her hormones.
So interesting, though, that the doctors wouldn't insist if you have breast cancer, you have to take these out. It seems very contradictory that they would then try do any sort of surgery with big balls of silicone in their way. Like it's just,
Oh yeah, the other thing she used in Mexico, but I think it's available, I don't know in Canada for sure, in the US, cryotherapy.
yeah, well, it's few and far between, but we definitely have a center here in Calgary.
Yeah.
Yeah,
So that's another option that you don't have to have your whole breasts taken off and chemo and
just
radiation.
freeze your breath.
You just, well, you don't freeze the whole breast, you just freeze that spot.
Yeah, so that was interesting. I'll look into that more and let you know because she definitely said low estradiol. She didn't
Yeah,
say high, so a bit more. And maybe I don't know. Yeah, I can't really comment too much, but it caught me, and I was like, oh, I'm going to ask Carol about that.
yeah,
Well,
I don't
thanks,
know, you got
Carol.
me too.
Yeah,
Okay.
thanks for another great chat, full of information. Got through pretty much all of my questions. So thank you for your time.
Oh, good. Thank you, Chemaine.
Might see you back soon in a few weeks. I was thinking maybe I can convince you to come back and talk about thyroid because that's something else you're great at.
Yeah, big problem.
All right, thanks, Carol.
Okay. All righty. Bye.